Hello everyone. Now we will be continuing our previous lecture of renal tumor, where we have previously discussed about the renal cell carcinoma and renal oncocytoma. Okay, now we will continue with our three remaining topic, that is the renal transitional cell carcinoma, squamous cell carcinoma and Wilms tumor. Okay, and these all are high yield topics, so we need to understand it. Okay, now about transitional cell carcinoma, we know that our urinary tract system are lined with transitional cell. Okay, the lining epithelium is known as the transitional cell, and the most common tumor, so it is the most common tumor of your urinary tract system, and it occurs in the renal calyx, pelvis, ureter and bladder. So when we talk about the kidney, then there is the minor calyx, major calyx, then renal, pelvis, ureter, urinary bladder and urethra, in this way with the kidney. So you see there is one major thing is that it is not talking about that this anatomical site are not involving the renal parenchyma. That is no involvement of renal tubules. It's begin from renal calyx, pelvis, ureter and bladder. Okay, so what is important is that in this carcinoma there will be no cast. There will be a hematuria. All cancer of your renal system will present as hematuria, and that will be painless. Whatever tumor, anywhere, if you are talking about the cancer, if you are talking about the tumor, then that is responsible for actually painless hematuria. Okay, now we are talking about the site. We know about the site presentation. We know why cast will not be there. If you have not seen one of my previous lecture of our renal cast, then please go and see, because we have explained very clearly about all the cast tests and what will be the disease associated with it. I'll further explain here. Since casts are formed in the renal tubules, there is a protein called TAM phosphol protein that's secreted into the tubules and get settled down and will take the shape of the tubules. Now this is after tubules, that is this is not, if there will be the before tubules, then there will be associated of renal cast, because renal cast are formed in tubules, renal tubules. But since this is after tubules, that renal cast is formed before that. So after that, if there is disease, then there will be no association of renal cast. That you have to remember. So renal cast, renal pelvis, ureter and bladder, in this type of any damage, any problem over there, there will be no cast. The cast will be only in the renal tubules and before that. Okay. Now there is one formula then associated to remember what are the risk factors that is responsible for your transitional cell carcinoma, and that is PSAC, that associated problem with PSAC, that is where we are talking about the urinary sac, and there is the phenacetin, okay, S for smoking, A for aniline dye, and C for cyclophosphamide. Among this, smoking, everybody you know that causes a lot of cancer, but you have to obviously think about the aniline dye and cyclophosphamide, because if they are going to give you a scenario, then they will mention about this in the history. They will mention about these dyes or use of cyclophosphamide, or they will direct tell you about a carcinoma and go back and ask you about anything like aniline dye, cyclophosphamide or phenacetin. So this is important and necessary to remember. It is easy to remember because this is just a formula of PSAC. This where P is phenacetin and S is sac for S for smoking, A for aniline dye and C for cyclophosphamide. Aniline dye mainly associated with the says many industries where the painters industries, that will be your case scenario. Okay, now coming to the squamous cell carcinoma, since we know that our urinary tract mainly lined with a transitional cell, but due to the chronic irritation of the urinary bladder, we are now focusing on the urinary bladder, but due to the chronic irritation of the urinary bladder, this transitional cell will be metaplasia. What is metaplasia? Metaplasia is that is conversion of one adult type of epithelial cell into the another adult type, and that is known as the metaplasia. Okay, there are many classical examples like bladder, esophagus, and there are other examples as well. Here also, due to the chronic irritation of the urinary bladder, what happens when there is a chronic irritation, then stem cell get the signal, and the type, according to the type of the signal, it changes the cell type. Like if you have a gastric reflux, then to handle the gastric reflux, the stem cell changes. In a stomach there is a columnar cell, in the esophagus there is a squamous cell that change into the columnar type. So that is main function of the stem cell. Since here it is getting chronic irritation, and due to irritation it has to now change it, and since it changes it goes on to the metaplasia, and after metaplasia there if occur dysplasia, dearens growth, then it will finally leads to carcinoma, and that is squamous cell carcinoma. Okay, so we have known about how this metaplasia and dysplasia and finally squamous cell carcinoma occur. What are these irritation? Now we have to remember what are the irritation that leads to this metaplasia, and the irritation are due to Schistosoma hematobium. Mainly it is mentioned in the Middle East in your first aid book, but it is in common in Nepal, in India, in Africa. But Middle East is also a place where we found is a major endemic places for Schistosoma hematobium, and that is the egg present into the urinary bladder that is chronically irritated and causes metaplasia and finally to the cancer. Then chronic cystitis, if a patient has chronic cystitis, chronic infection of the bladder, that will also lead to your metaplasia and finally to cancer. Then smoking and chronic nephrolithiasis. If there is a stone is present, it will chronically irritate the epithelial lining and leads to the metaplasia and finally to the cancer. Okay, so we have also understood now about squamous cell carcinoma and about Schistosoma hematobium. They will even Schistosoma. There are three types: Schistosoma hematobium, Schistosoma mansoni, and Schistosoma japonica. Okay, but you have to remember this Schistosoma hematobium and its eggs. We'll talk in the microbiological section that egg, there is a spine, terminal spine, side spine, rudimentary spine, that depends on it. Okay, so we are talking about there will be a terminal spine. So this, if there is a egg and there will be like this. So this is the egg and there will be a terminal spine. This is egg of Schistosoma hematobium, and we'll talk about it in detail in our microbiology discussion section as well. Okay, now let's come to the chronic cystitis we have talked, and the presentation will be obviously painless hematuria, and that we have already discussed about it. Now let's come to an important topic of Wilms tumor, that is known as a Nephroblastoma, and it is a tumor of the childhood. In the childhood, mainly is group 2 to 4. So it is known as a childhood tumor, that is a Wilms tumor, and is the most common renal malignancy of early childhood. And because since it is present in the childhood as well, that contains the embryonic glomerular structure as well is present. Okay, and the presentation of the patient, how it will be the since there is a tumor, then there will be a palpable mass, large palpable unilateral flank mass. Okay, and it may or may not be associated with hematuria. So presentation will be in that domain. There will be unilateral large palpable mass in the flank. Okay. So why this has occurred? Why the child has born with this tumor? And it has occurred because there is a mutation in a tumor suppressor gene. You know that about the tumor suppressor gene. So since there is a mutation in the tumor suppressor gene, it has led to the Wilms tumor. And what are those genes? Those genes are WT1 and WT2, and that's are found on the chromosome number 11. So what we need to remember, Wilms tumor, most common, we know about that, which is the most common tumor in the early part of our life, and that contains the embryonic glomerular structure. That is not also important to remember. There is a presentation like flank mass, unilateral, okay, which may be associated with the hematuria, large palpable flank mass is there, that way also we can think. But we need to remember that it is occurred due to the mutation in the tumor suppressor gene, and that is WT1 and WT2, and that is present in the chromosome number 11. Okay. Now, this Wilms tumor are associated with lots of syndrome. We will discuss most three which was mentioned in your FA, that is first aid. Okay, so the first syndromes is WAGR, Weger complex, and that contains, obviously all three will contain the Wilms tumor, but there will be the other associated finding, and according to that associated finding we have to decide that this belongs to this syndrome, and that is important actually. Okay, so we need to remember that. Weger complex, WAGR, Weger complex is Wilms tumor. Aniridia means absence of your iris. Okay, so Wilms tumor, aniridia, genitourinary malformation, and mental retardation. So Wilms tumor, W for Wilms, A for aniridia, G for genitourinary malformation, and R for mental retardation, and that is mutation to the WT1. Okay, When you talk about the Dennis-Drass syndrome, the Dennis-Drass, there will obviously Wilms tumor is present, but the other associated feature will be like early onset nephrotic syndrome and male pseudohermaphroditism. That is associated finding. So male pseudohermaphroditism and early onset nephrotic syndrome with your Wilms tumor, that is becomes the Dennis-Drass syndrome. Okay, then there is another term like Beckwith-Wiedemann syndrome, and then this Beckwith-Wiedemann contains obviously Wilms tumor. Then there are other features like macroglossia, your tongue will be enlarged, organomegaly, every organ will be enlarged, and there will be the hemihyperplasia. The difference is that the above two, Weger complex and Dennis-Drass syndrome, are due to mutation of WT1. That is present in chromosome 11. But this Beckwith-Wiedemann is where these are the two Wilms tumor, macroglossia, organomegaly is due to mutation of WT2. It's not 1, it's 2. It's 2 and this one is 1 mutation, and they both are the chromosome 11. Okay. So hope this I have made it easy to make you understand and made to remember, because these are the high yield topics and they will be question mode. Okay, thank you.